Welcome back to MLT 130. This is part 2 of the electrolytes lecture. The next electrolyte we're going to discuss is bicarbonate. Bicarbonate is the second most abundant anion in extracellular fluid. It's the major buffering system of the blood, so it helps maintain the pH homeostasis of blood. Total CO2 is comprised of bicarbonate, so you will hear bicarb and CO2 used interchangeably. You will have all three forms of bicarbonate, carbonic acid, and dissolved CO2 in your body. Your body will go from one form to the other depending on its need to raise or lower pH. Bicarbonate helps comprise more than 90% of normal pH, and the measurement of total CO2 is indicative of bicarbonate. In clinical applications, bicarbonate helps with the acid-base balance and decreased bicarbonate metabolic acidosis. It's compensated by hyperventilation. You can have an increased PCO2 or partial pressure of carbon dioxide in arterial blood. This is again indicator of respiratory function and closely related to factor to acid-base homeostasis, reflecting the amount of acid in the blood. You can have increased bicarb or metabolic alkalosis, and it's compensated by hypoventilation or decreased partial CO2. For determination, our specimens for bicarb include serum or plasma, and these samples must be capped and remain capped because they can decrease by 6 millimoles per hour without the cap on the tube. The method for the determination is our ISE method. It's the one that's used most often, but we can also use enzymatic methods for testing. Next, we need to discuss what the ion gap is. The ion gap is the measurement of the difference or gap between the negatively charged and the positively charged electrolytes. Routine electrolytes that are usually included in the ion gap are potassium, sodium, chloride, and bicarb. The ion gap determines the difference between the unmeasured anions and the unmeasured cations. There should not be a gap between the positive and negative ions. If the ion gap is too high, your blood is more acidic than normal. If the ion gap is too low, your blood isn't acidic enough. It's useful in indicating an increase in one or more unmeasured ions, and is also used as a form of QC. Consistent gaps in normal patients may indicate an instrument problem. Some common blood panels that a ion gap is run in is a CMP or comprehensive metabolic panel, or a BMP basic metabolic panel, or just your electrolyte panel. Here's a couple of different formulas that you can use for the ion gap and their normal ranges. So your ion gap can be calculated using sodium minus chloride plus bicarb, or the other formula is sodium plus potassium minus chloride plus bicarb, and your normal ranges are there under each formula. So let's go back to that original slide where we introduced ion gap and look at that chart. So here would be your ion gap, the difference between your cations and your anions. And this would be your ion gap. And you can calculate that using one of those formulas. The next electrolyte we're going to talk about is magnesium. Magnesium is the second most abundant intercellular cation. So it's a positive charge, intracellular, meaning it's inside the cells. About 53% of magnesium found in the body is found in the bones. About 46% of magnesium can be found in things like the muscle, organs, and soft tissue. Some of the things that magnesium helps with in the body, it plays a role in nerve and muscle relaxation. If we didn't have magnesium, our muscles would cramp up. It also plays a role in the potassium or sodium potassium pump in moving ATP across cell membranes. Magnesium combines with ATP and helps with transfer. It also helps maintain blood pressure and magnesium is absorbed in the gut. Also, less than 1% of magnesium can be found in the serum and red blood cells. About a third of that 1% can be found bound to albumin, and 2/3 are free, ionized, and bound to other ions. The free percentages of magnesium are physiologically active. The normal range for magnesium in serum and plasma is 1.7 to 2.2 milligrams per deciliter. Some other function of magnesium include it's an essential cofactor for more than 300 other enzymes, and it's needed for cell energy or metabolism, nerve conduction, and it regulates potassium with that sodium potassium pump or movement across cell membranes. As far as regulations, our source is we get it from the diet. Our magnesium is controlled by the kidneys. We can excrete excess magnesium. Our parathyroid hormone can increase reabsorption along with calcium, and aldosterone decreases reabsorption. Low magnesium levels would be rare in unhospitalized patients. It's usually as a result of reduced intake in the diet of magnesium. It can be a result of chronic alcoholism, decreased absorption, or increased excretion. That excretion could be due to renal issues, or it could be drug induced. It could be a result of diuretics, pregnancy, or excess lactation. Symptoms of hypomagnesia could include cardiovascular problems, neuromuscular problems, and metabolic problems. Hyper or increased magnesium would be the opposite. You would have decreased excretion, hyperendocrine states, an increased intake of magnesium from sources like antacids, enemas. You could also end up with increased magnesium due to dehydration, bone carcinoma, or metastasis. The symptoms for hyper include symptoms like cardiovascular symptoms, including hypertension or bradycardia. Bradycardia is a type of abnormal heart rhythm or arrhythmia. Neuromuscular symptoms like respiratory depression, paralysis, and dermatological symptoms such as flushing or warm skin. Our specimens for magnesium can include non-heparinized serum that needs to be separated as soon as possible, and plasma. EDTA is not acceptable because it binds with magnesium. Our methods are colorimetric methods. This is a method of determining the concentration of a chemical element or chemical compound in a solution with the aid of a color reagent. The limitations are that it may not reflect intercellular magnesium. 25% protein bound does not reflect physiologically active free ionized forms. The next electrolyte is calcium. Calcium plays a role in bones and teeth, as well as muscles, nerves, and even blood clotting. Calcium is absorbed by the gut and stored in the bones. If calcium gets too low in the blood, the bones can release calcium into the blood. If it happens a lot over time, bones can become weak. Calcium is the most prevalent cation in the body. The distribution is about 95% in bones, and the rest is in soft tissue and extracellular fluid. Plasma forms of calcium include 50% ionized biologically active calcium, 40% protein bound in albumin, and then about 10% complex with other ions. And the total calcium normal range is 8.8 to 10.3 milligrams per deciliter. Calcium is regulated by 3 different things. In order for calcium to be absorbed, a person has to have vitamin D. The parathyroid hormone also helps regulate calcium. And also calcium, in order for it to be regulated, calcitonin needs to be provided by the thyroid gland. and it needs to be in working order. Some things you need to know about calcium as far as lab testing and surgery. Calcium binds to citrate, phosphate, and bicarbonate during surgery. Lactate will change rapidly during surgery, so it's essential that ionized calcium is performed rather than the total calcium. Ionized calcium is calcium in your blood that is not attached to protein. It is also called free calcium. As far as calcium regulation, we mentioned this before, but the parathyroid stimulates reabsorption of bone to mobilize the calcium and phosphate and decreases renal excretion and stimulates the renal production of active vitamin D. The vitamin D increases intestinal absorption of both and enhances the effects of the parathyroid on bone reabsorption. Calcitonin lowers calcium. As far as intercellular functions of calcium, it helps with muscle contraction, hormone secretion, glycogen metabolism, and cell division. For extracellular functions of calcium, it helps with bone mineralization, plasma membrane potential, coagulation, and muscular contractions, especially with the cardiac muscles. Clinical significance of hypocalcemia or low calcium. It causes hypoparathyroidism, and this can be a result of thyroid surgery where the thyroid has been removed or damaged. Vitamin D deficiency can also cause low calcium, or renal disease can cause low calcium. It's important to monitor ionized calcium for surgical patients and critically ill patients to promote good cardiac output and blood pressure. This is because our transplant patients and open heart surgery patients receive large quantities of citrated blood. Ionized calcium binds with citrate, phosphate, bicarbonate, and lactate, and those concentrations change rapidly during surgery, so it's essential that the ionized calcium test is performed rather than the total calcium test. Hypercalcemia is too much calcium in the blood. This is, or the primary cause, primary hyperparathyroidism, where there's too much released or too much calcium released. It can also be caused by hyperthyroidism, multiple myeloma, or an increase in vitamin D, or you're taking too much of a vitamin D supplement. Our specimen of choice for calcium is serum or heparinized whole blood. For the ionized calcium, it must be collected anaerobically. Loss of PCO2 will increase pH and cause more calcium to bind with the protein. EDTA and citrate are not used because it binds with the calcium and interferes with methodologies. We must leave the cap on the tube for our calcium samples. We use the ISE as our methodology. The last electrolyte we're going to discuss is phosphate. Phosphate is regulated by the parathyroid gland. The parathyroid can tell the kidneys to inhibit reabsorption. Phosphate is the most abundant intercellular anion, or inside the cell. Phosphate participates in many biological processes and is found in the teeth and the bone processes, is stored in the bone and absorbed by the gut and excreted by the kidneys. Vitamin D affects how we're able to absorb phosphate. Phosphate is needed to make phospholipids, cell membranes, and cytoplasm, and compounds important to biochemical energy storage and exchange. In plasma, we have an inverse relationship between phosphorus and calcium. Phosphate is absorbed from food, it's released from the cells, it's lost from the bone. Renal excretion and reabsorption helps maintain phosphorus at constant levels. Vitamin D increases intestinal absorption. Reabsorption happens in the kidneys, and the parathyroid inhibits reabsorption of phosphate. Hypophosphatemia can be caused by diabetic ketoacidosis, inflammatory bowel disease. ICU patients with sepsis can end up with hypophosphatemia, and patients that are severely low as far as phosphate end up with about a 30% mortality rate. On the opposite side, hyperphosphatemia can be a result of acute or chronic renal failure or increase of intake. Neonates usually have higher phosphate levels. You can have hyperphosphatemia as a result of increased cell breakdown or lymphoblastic leukemia. Children have higher levels than adults as a result of growing bones. For our sample and determination for phosphate, our sample is serum or heparinized plasma. Oxalate citrate or the EDTA is not used because it can interfere with analysis. And the method that's usually used for testing is a colorimetric method. This concludes part 2 of our electrolytes lecture. If you need any help or need any clarification, don't hesitate to reach out, and I will see you in our next lecture.